of this LDI project. So my topic is estimation of postpartum blood loss. So normal blood loss during delivery. Blood loss during vaginal delivery varies from 400 to 500 ml. Caesarean births are associated with 500 to 800 ml of loss, and postpartum loss without prophylactic uterotonics ranges from 450 to 500 ml compared with 200 to 300 ml in women receiving uterotonics. So PPH is blood loss more than 500 cc in normal delivery, more than 1000 cc in caesarean section, and any amount of postpartum blood loss that destabilizes the women's vitals. So why do we need to estimate blood loss? It helps in early diagnosis of PPH, minimizes risk of hemorrhagic shock, helps in timely resuscitation, reduces maternal morbidity and mortality. And now, what are the methods of estimation of postpartum blood loss? So, clinical assessment, visual assessment, standardized visual assessment, direct assessment, gravimetric method, photometry, and miscellaneous. So, visual estimation of blood loss. It is a primary method of determining blood loss, subjective and imprecise. So, there was a study by Rachel Phillips on visual estimates of blood loss by medical lay people, effects of blood loss, volume, victim, gender, and perspective. A total of 125 lay people watched 78 short videos, each of individuals experiencing a hemorrhage. Lay people overestimated small volumes of blood loss, underestimated larger volumes, and larger volumes of blood loss were associated with larger estimation errors. So you can see in this slide that the black line shows mean estimates with 95% CL as error bars. The dashed gray line indicates an accurate assessment. So this is the accurate assessment, and the dark line is the real blood loss, estimated blood loss. The confidence interval showed that blood loss in the lower ranges were overestimated as the confidence interval exceeded the true volume. For 300 ml, the 95% CIs overlapped the true amount, whereas volumes from 400 to 1900 ml were underestimated. So overestimation may result in unnecessary and costly interventions, and underestimation may delay identification and diagnosis. So this results in an unplanned obstetric emergency with catastrophic outcome. Now, standardized visual estimation. The observer is trained to determine the blood loss using a single collecting container and fixed sized gauze pads of different sizes using simulated scenarios with known measured blood volumes. Visual estimation is more accurate when the blood is collected in containers rather than pads and clothes. So, in Tanzania, traditional birth attendants have used a method to identify excess postpartum blood loss in home births by placing standard size kangas, 100 centimeter into 155 centimeter cotton cloth under women during and after delivery, and a trial found 2 soaked kangas predicted an average blood loss of 500 ml. A consistent size and weight of the cloth is critical to widespread use of this method. So this is a pictorial guide to blood loss at obstetric hemorrhage, and the staff has to be trained, the doctors have to be trained in this. Now the second method is the clinical method. Clinical estimation remains the primary means of diagnosing the extent of bleeding and directing interventional therapy in obstetric practice. Classification of hemorrhage can be based on a graded physiological response to the loss of circulating blood volume. And here in this slide, you can see that it needs almost 30 to 40% of blood loss when the blood pressure decreases and the pulse pressure is also decreased. So a large volume of blood loss occurs, then only the clinical signs become evident. The modified shock index is a bedside assessment to estimate hemorrhagic shock. defined as heart rate to mean blood pressure, with a normal range of 0.5 to 0.7 in healthy adults. So, when the modified shock index is more than 1.4, then this is a very dangerous situation, and this denotes that the patient is in severe shock. A systolic blood pressure below 100 mm of mercury and a pulse rate above 100 beats are late signs of depleted blood volume. It indicates commencing failure of the compensatory mechanisms, and acute blood loss might not be reflected by a decrease in hematocrit or hemoglobin level for 4 hours or more. Significant cardiovascular changes occur immediately postpartum. The cardiac output remains elevated for 24 hours. Blood pressure declines initially and then stabilizes on the postpartum day 2. And maternal physiological changes of hemodilution lead to reduced hemoglobin and hematocrit values, reflecting the importance of timing of the measurement. In the majority of patients, no single timed hemoglobin or hematocrit determination in the first 24 hours postpartum will detect the peak. A diagnosis when the patient is at class 1 stage shock is very important, as women can progress into class 2 rapidly, and at level 3 without prompt appropriate intervention, women can progress to shock. So, pregnancy is a hypervolemic state. Nearly 50% increase in cardiac output and blood volume occurs, and up to 30% loss of volume, 1500 to 2000 ml is required to alter vitals. And in this slide you can see key blood pressure remains stable until 25 to 30% of the volume is lost. Now, direct collection of blood into bedpan or plastic bags. This approach was used in the WHO multicenter randomized trial of misoprostol in the management of third stage of labor. In this trial, blood loss was measured from the time of delivery until the mother was transferred to postnatal care, and immediately after the cord was clamped and cut, the blood collection was started by passing a flat bedpan under the buttocks of the woman. Blood collection and measurement continued until cessation of the third stage of labor up to 1 hour postpartum, and the collected blood was then poured into a standard measuring jar. All gauze swabs soaked with blood were put into the measuring jar and included in the measurement together with the blood and clots. A validity study was performed before the trial to assess the effect of adding the gauze swabs. This process increased the blood loss measurements by approximately 10%. The errors associated with collection of blood by any of the methods are numerous. They are compounded by ignoring maternal blood within the placenta, approximately 150 ml, and spillage. Confusion related to the mixing of blood contaminated with amniotic fluid and urine, and technical inaccuracies associated with transfer of the collection to a measuring device. So this is the pan which is put under the buttocks of the woman. This is the Kelly's pad. This is also a collection device. Now, gravimetric method of blood loss estimation. The gravimetric method was first described by Wangstein. It depends on weighing surgical sponges before and after surgical use. An estimated blood loss is determined by assessing the weight difference before and after use, with every gram of weight equivocal to 1 ml of blood loss. This method is inexpensive, simple, and practical for measuring estimated blood loss, but neither precise nor accurate. Inaccuracies can arise at several steps in this procedure, including lack of international standardization of size and weight of the gauze, sponges, and pads. So, subtract the known dry weight from the weight of soaked materials. 1 ml is equal to 1 gram. Now, determination of changes in hematocrit and hemoglobin. Changes in the hematocrit and hemoglobin values before and after delivery provide quantitative measurements of blood loss. The American College of Obstetricians and Gynecologists cites a 10% post-delivery decline in hematocrit compared with pre-delivery as a secondary definition of PPH, but notes that postpartum hemoglobin and hematocrit concentrations do not always directly reflect hematological status. Routine hematocrit determination is possible where equipment is available. However, routine postpartum hematocrits are unnecessary in clinically stable patients with an estimated blood loss of less than 500 ml. After delivery, associated with an average blood loss, the hematocrit drops moderately for 3 to 4 days, followed by an increase. The peak drop may be appreciated on day 2 or day 3 of postpartum. By days 5 to 7, the postpartum hematocrit will be similar to the pre-labor hematocrit. And should the postpartum hematocrit be lower than the pre-labor hematocrit, it is an indication that blood loss may have been larger than appreciated. So this is the fall in hematocrit and again rise. Spectrophotometric estimation of blood loss. This is based on collected blood being mixed with a standardized solution which converts hemoglobin to acid hematine or cyanomethaglobin. This in turn can be measured by a spectrophotometer or colorimeter. Use of the acid hematine method of calculating blood loss is impracticable in obstetric care. Now, colorimetry with artificial intelligence. Smartphone application is used to calculate blood loss. The app analyzes the photographs of used surgical gauge or canister taken by the phone and then filters out the effects of non-blood components mixed into each sponge and canister. The hemoglobin mass present in the gauge or canister is then subtracted from the pre-operative hemoglobin level, but more data are needed before it is recommended for clinical use. So this is the app. Decreased inferior vena cava diameter as an early marker in postpartum hemorrhage. This is also being studied. Then I'll present before you a study, quantification of blood loss for the diagnosis of postpartum hemorrhage, a systematic review and meta-analysis. It was a total of, by Ruiz, a total of 14 studies from America, India, Australia, Thailand, England, Saudi Arabia, total of 20,763 childbirth, 5,341 cesarean sections, and 14,378 vaginal births. This study inferred that quantification of loss by any method was superior to visual estimation and is highly recommended. Accurate estimation of postpartum blood loss is a challenge for obstetric care worldwide, and in this meta-analysis there was greater blood loss in cesarean section when compared to vaginal births. Vaginal childbirth is the childbirth route with the greatest challenges for measuring blood loss, since it is not possible to control variables related to secretions present during labor and the immediate postpartum period, such as amniotic fluid and urine, which may overestimate or underestimate the estimates made in different methods. Visual estimation was described more frequently. It was the most used method in the obstetric care for this purpose. Its accuracy depends on the control of several variables, such as the expertise and experience of the professionals who are assessing it, being considered subjective and difficult to reproduce. Although it presents zero cost, it is flawed with overestimation in small losses and underestimation in large losses. This can waste unnecessary resources such as transfusions, delayed diagnosis and treatment, and may compromise postpartum women's health. Studies that assess the use of gravimetry through simple weighing showed great heterogeneity, similar to what was found in other studies. Studies found out as possible confounders and limitations of the technique, the presence of other liquids, amniotic fluid, bus 2 minutes, diuresis, sweating that can overestimate the loss, and absence of well-defined protocols. Furthermore, the possibility of human error in accounting for losses is highlighted. The need for an accuracy scale, periodically calibrated, is also described as a difficulty for carrying out gravimetry. Many of these materials can absorb the liquid part of the blood, causing it to evaporate and translate into a smaller quantity. Quantification is recommended for the diagnosis of PPH in all types of childbirth. It provides objective measurement which impacts on PPH recognition and treatment. It presents better results when compared to visual estimation. It is low-cost resource as it only requires calibrated scales and trained professionals. The impact of use of calibrated and graduated fields, collection bags attached to the parturient woman, was not observed in the present review. A review study of quantification of blood loss in vaginal childbirth showed greater accuracy than gravimetry. It is a low-cost resource and its use should be considered in clinical practice. Changes in vital signs appear when considerable amount of blood has been lost, and assessing the shock index is strongly recommended for the diagnosis of PPH. Although accurate quantification by lab method is rarely used, and it should be noted that a study found a correlation between a 10% drop in the hematocrit level on admission and postpartum. Colorimetry is the method with the most recent description in American literature. It is one of the most accurate methods of quantification. It involves greater cost and complexity. Studies prove that simulation is capable of promoting cognitive and behavioral education with superior results, and it constitutes an important strategy to increase the clinical experience of both students and professionals, and is highly recommended in cases of PPH. So 1 woman dies for every 190 births, and the risk of dying from maternal causes is greater in developing and underdeveloped countries. In Asian countries, the chances of dying from PPH is 1 in 280, in Africa 1 in 39, and in countries belonging to Oceania 1 in 170, and in European countries 1 in 4300. So it is noteworthy that it is in these countries that financial resources are scarcer. Effective and more accessible prevention and early identification methods need to be implemented with greater urgency. So PPH has been and continues to be a significant concern. Methods to accurately determine blood loss are desperately needed, and so that timely interventions to decrease PPH can be done. So women die from PPH because they do not receive early initiation of effective interventions. So save mothers, stop PPH. Thank you very much.
Thank you, Alkadi.
Thank you.
For the final talk of the session, I would request Dr. Preeti Kumar to speak on emotive PPH bundle approach. Preeti is the chairperson of the Maternal and Perinatal Committee of SAFOG. She was the chairperson of Safe Motherhood Committee of Pphcon. Madam, Alka Madam, please come and sit here. From 2020 to 2023, she is also a committee member of MFM Committee of AOFOG and Joint Secretary of India Gestosis Chapter. She is a professor and HOD of Obs and Gynae at Narayana Institute of Medical Sciences, Kanpur. Over to you, Preeti.
Thank you so much. So, especially the first and foremost thanks to all of you who are sitting here till the end of the day. So, probably I'm the last batsman of today's session. Extremely grateful to Dr. Meena and Dr. Amita for inviting me here, and of course, heartfelt gratitude to Dr. Rishikesh Pai sir for involving me in this leadership development initiative. Thank you, Dr. Bhaskar sir. And just to, I'll not take much time, but still I would like to highlight some of the ground realities of our country, because a lot of work has been done in the PPH. And this leadership development initiative, which is led by Dr. Pai, is basically focused on anemia and PPH. So if I talk about the prevention of PPH, I would say 2 things. One is anemia, the second one is the active management of 3rd stage of labor. And believe me, trust me, the analysis, whatever we have done so far, about more than 2,500 healthcare workers and more than 500 doctors, active management of the 3rd stage of labor is the biggest challenge in our country. Most of us are not aware exactly about the active management of 3rd stage of labor. So how many of you know about the emotive bundle? Just raise your hands. How many of you know about the emotive? So, very good. So I'll just mention what emotive is. The first thing that we need to redefine is the PPH management, is the definition. That any amount of bleeding, why this definition has been redefined, the clinical definition, because any amount of bleeding after the birth of the baby of any rate of amount that has potential to deteriorate the general condition of the mother is called PPH. Because most of the pregnant women, more than 50% are anemic in our country. So we cannot take that definition of 500 and 1000 ml, we have to cut down and make the criteria of defining PPH and early intervention in these cases. postpartum hemorrhage is a leading cause of maternal mortality. More than 14 million women experience PPH, out of that 70,000 die. I am sure this data is still lacking. Many, many mothers die of PPH. Now, there is an urgent need to find out the bottlenecks. This is why Dr. Pai has been invited by WHO, and WHO expects a lot in India. Why? Because if you see this graph in South Asian region, India is tops, because the deliveries are more, therefore the prevalence and incidence of PPH is very high in India among all the South Asian region. So in South Asian region, PPH contributes to about 36% of all maternal deaths. And when you stand at the global platform and you say that India has the highest prevalence of PPH, it is very shameful for us. So for every OBGYN and every healthcare worker, we have to take this step forward. The facts show that women die every 2 minutes due to pregnancy or childbirth, and one mother dies every 6 minutes due to PPH, and postpartum hemorrhage is scary, not always predictable, but absolutely treatable. Active management of third stage of labor. We must learn about active management of third stage of labor. I just want to add what Dr. Basav has said, that the carbopros is the only uterotonic which is not recommended for the active management. It is only for the management of PPH. So these are all FIGO recommendations. All has been said by Dr. Basav. Again, the FIGO says that the uterine massage, which is one of the component of active management, is no longer a component of active management. Instead, you have to assess the tone of a pregnant, of a delivered woman and see whether the uterus is relaxed or not. Now, WHO has given the statement that a trial of set of interventions to manage postpartum hemorrhage published in New England Journal and Medicine found 60% reduction in the heavy bleeding. And these are the life-saving solutions, dramatically reducing the severe bleeding after the childbirth. A new solution known as E-motive, I'll just tell you what E-motive stands for, could provide a major breakthrough in reducing the deaths from childbirth related to bleeding, according to the landmark study published by WHO and University of Birmingham. So this study, which involved over 200,000 women in 4 countries, found that objectively measuring blood loss using a simple low-cost V-drapes. We usually do visual estimation, which is not the correct method. Please use V-drapes. These are just costing around 160 rupees. Rather than offering and then you offer a WHO recommended treatments rather than offering them sequentially, resulted in dramatic improvement in the outcomes of the method. Severe bleeding when the woman loses more than a liter of blood after birth was reduced by 60% when we applied the E-motive bundle approach. The recommended E-motive package includes the first and the foremost is the early and accurate detection of PPH by collection drapes. I'm sure none of us sitting here are using drapes right now. We usually do by the visual estimation, and complemented by the immediate treatment bundle, that is uterine massage, medicines to contract the womb, intravenous IV fluids, and examination and escalation. The major challenges responding to PPH were the PPH was detected too late. So when we did this FIGO, before Dr. Pai sir, we had a different project of FIGO, which we did in UP. You will not believe that the prevalence and incidence of PPH was as high as 20 to 25%, which the literature shows 5%. So it is that high because we don't document it and we don't actually detect it early. Most providers use visual estimation of the blood loss, and which tends to underestimate the blood loss and can lead to life-threatening delays in the treatment. When treatment is provided, this is typically done in a sequential manner, with the gaps between each intervention costing more time in the first options are not effective. कहने का मतलब ये है कि if you take a stick, it is weak. But if you take a bundle of stick, it is more strong. So the only thing is you have to do all the steps together of E-motive so that you get a better outcome in the PPH. So this is the chart. With this, I'll end my presentation. Now, this is the E is the early detection, which I think Dr. Alka has already talked about. Early detection by using a brass V-drape. This is a focus of WHO. They are doing multi-central trials where they want to actually estimate the amount of blood loss. M stands for massage of the uterus. Again, I want to highlight that the individual assessment, clinical assessment of the patient is very important. Suppose if you have delivered the patient, you are putting on the gloves, immediately do a bimanual uterine compression. So these are the steps that you need to do it together Do not waste time. So E stands for early detection, M stands for massage, O stands for oxytocin. Again, I show you the chart. Most of us do not know about the half-life, the duration of oxytocin, what are the side effects. Side effects we know, but how long the eutotonics last is again very, very important. So again, I think this was a question, sir, when Dr. Madhuri sir called me from UK. The question was, when do you add the second eutotonic when you are managing a PPH? So what we do is we overload with the eutotonics. This is not correct. The first drug of choice is always oxytocin, and then gradually every OBGYN should know about the half-life and the duration of oxytocin. You have to give that much of time, and then you add on the second eutotonic. Then tranexamic acid, I think Dr. Basab has talked about it. 1 gram tranexamic acid for the management immediately, simultaneously, as soon as you detect PPH. The maximum response occurs within 3 hours of PPH. This is all the trials which have shown that it causes a reduction in the maternal mortality by 1/3. IV fluids, again, crystalloids are preferred, and examine and escalate if the patient is not responding to it. The similar approach was given by FIGO. We talk about the bundle approach. First is the AMTSL. The second one is the first response bundle, again the E-motive, then supportive measures, and then refractory interventions. I think you have been learning about all these things in past, and then supportive measures for surgery and referral and all those blood transfusion. This I'll skip. Again, important to understand is always consider the BMI of the patient, because this is related to the blood loss. It is kg into 100 ml. Like if the weight is 35, the blood volume will be 3,500 ml. So studies that 15% of the blood loss will be different in 30 kg weight and a 35 kg weight. So it is important to keep the BMI also in loop. So these are all list of oxytocins. We should know about it. Again, if you use misoprostol for prevention of PPH, then do not use it for management, because the studies show that the further use of misoprostol, if you have used it for prevention, is not effective. This is the chart which I was talking about. The onset of action, how long the duration of action lasts. Again, it is very, very important. Just to give you a small example, if a patient has a prolonged labor and she is having a repeated uterine relaxations and she is repeatedly having a relaxed uterus, perhaps the ergometrin will be the best choice, because it lasts for a longer period of time, 2 to 4 hours, rather than oxytocin. Oxytocin has a very short half-life. That is why it is given in infusion. It is not given as IM. We give it for prevention only, but for the management we give it in infusion, because the half-life of oxytocin is very, very less. IV fluids, again, the concept has changed. Don't over-infuse the patient. Try to replace with the blood and blood components. Don't try to over-infuse, because this causes coagulopathy, and aggressive resuscitation may worsen coagulopathy and hemorrhage by increasing the intravascular hydrostatic pressure. So try to just keep the blood pressure above 80-90 and try to find out the bleeding cause of the bleeding and replace it more by a blood rather than giving too much of fluids. This is women trial. Dr. Basav has talked about tranexamic acid. Women 2 trial, if the results come, that it can be used as a prevention in anemic patient. I think this would be the best study for a country, because 50% of the pregnant women are anemic. So with the active management, you also give tranexamic acid. The results are waited for women 2 trial. Tranexamic acid, give 1 gram in 10 minutes, and then you can repeat it. If the bleeding is not stopped in 30 minutes, you can again repeat it. Look at the contraindications. If there is any thromboembolic episode, do not just give tranexamic acid. Shifting from vitals to shock index is again a new parameter, because vitals sometimes will not ensure the patient's stability. Shock index is a better parameter. I think Dr. Alka has talked about it. Try using shock index in these patients. Refractory management, we should be aware about actually putting on NSG, how suction is done, or whatever Dr. Samarth Ram has told, or UBT, whatever device, just stop the bleeding. That's the priority, and we should be aware about how these procedures are done. E-motive interventions, implementation strategies are again, facility should be prepared, specific training, PPH trolleys, or even PPH corners we have created in some of the centers. ORRT is obstetric rapid response team, which is prepared for managing any of the emergencies. Engagement of local champions, this is how we are here, debrief and proper referral and audits. So just showing you some of the glimpses, these are the facility readiness which we did in Jeevan Dhara. Dr. Thomas from MGH, Harvard University, he came down, he wanted to visit one of the private facility. This is how we create the PPH corner. Everything is put in one place, including the ESM UBTs and all the catheters, whatever you are using, and NASGs. This is a kind of ORRT we create. You put the patient as who will be the leader, who will be the team assistant. This is how the teams are created in the labor room. This we did in the district hospital when we took this FIGO project with the Pphcon in the state of Uttar Pradesh. So these are some of the IC materials that should be distributed. We had these with the Safe Motherhood Committee when I was as a chair, and we distributed these to all the facilities which we trained for Jeevan Dhara. Then debriefing is again very, very important. When you manage any patient, always try to analyze what went well, what went wrong. Because debrief forms are available like this, and you just check what steps did you do it correctly and which were not done actually in these patients. This will improve your again, referral. I think Dr. M.C. Patel sir has talked a lot about it. I'll skip these of the slides again. This was the first workshop what Dr. Pai sir, he gave us the permission to conduct this workshop in Arwal Medical College, and this was recently done on the Women's Day on 8th of March, where 94 participants were there, and we talked about the emotive. As you can see, we did the hands-on training. This was attended by the interns, staff nurses and doctors at the same platform. So we talked everything on the same platform with the staff nurses also. So everybody was there. We had 93 participants, and this is a kind of a chart we collected before giving the training and after the training. So look at the improvement after these, because these are very simple measures that can be taught. So orange is before training and blue bars show after training how much they have learnt in this 4 hours workshop. Again, few glimpses of Jeevan Dhara. This is again a groundwork which has been done in India, Nepal and Sri Lanka with the support of Pphcon leaders, Dr. Alpesh, Dr. Shanta, and of course Dr. Rishikesh Pai. And it was supported by government and other NGOs. Every organization came forward to help us, and we did this in UP, Bihar and Jharkhand. So it was a huge project. It was not a webinar. It took almost 7 to 8 months to prepare these centers. So it was a challenging task, and we used to take the monthly progress report, how the PPH is managed and how things are going on. And we also visited some of the remote CSCs in UP. So these are some of the glimpses I want to show that this is a doable option. And as a leadership development initiative of Pphcon, everyone should behave like a champion and try to help Pphcon and show the world that we can do a lot of things. So kind of a certificate of appreciation was given to all, and then we did this training in Nepal also, and recently, sir, we are doing the refresher course again in Nepal during the NISOC conference, and we really feel proud because Pphcon supported Nepal with ESM UBTs, with NSGs, with charts, everything. We supported Nepal for these PPH trainings. So again, we did this in Sri Lanka, 280 midwives attended, and then you have a lot of success stories when you treat them. So these are some of the success stories which are shared with us with the Jeevan Dhara facilities, how the lives of the mothers were saved even when the doctor was not there. So to conclude, emotive bundle care of PPH management is a doable option in our country. Believe me, the surgical interventions hardly will need 20 to 30%. 70% of the patients will be managed by medical management, and addressing postpartum hemorrhage needs a multi-pronged approach, and every woman, no matter where she lives, should have access to timely, high-quality maternity care with trained health workers, essential equipment and shelves stocked, and appropriate and effective commodities to prevent severe hemorrhage during the childbirth. So this is my last slide. Reset, readjust, refocus, restart as many times as you need, but just never give up. Let's ensure that no mother dies of PPH. And as a Pphcon, we need to focus on that red zone. This is India where the red zone is. Here the maternal mortality due to PPH or otherwise is very, very high. So our focus should be more towards this red zone, where I also belong to. UP is one of the state. So thank you so much, Dr. Pai sir, and thank you everyone for patient hearing, and thank you, Dr. Bhaskar and everyone.
Does anyone have any questions or comments? Why don't you come up, Rishikesh?
No, so what the question is, in the cesarean, how do you estimate the loss? Because first you will do the suction and amniotic fluid will also come into the suction bottle. So you will have to empty that, and then otherwise how would you estimate the 1000 ml loss?
Cesarean has separate drapes, but you are absolutely right. Basically the it all gets mixed up.
So the thing is even when we are doing a vaginal birth, initially the amniotic fluid has to be drained out. After the birth, then the drape is put in and then you measure so then also the suction has to be done, the amniotic fluid has to be drained out and then you have to measure the blood. Yes. नहीं सर उसको अलग
Not in cesarean. Cesarean incision में time भी होगा.
वो करना जरूरी है ना. That means we don't change the like the suction, as I remember. You don't change the bottle. उसमें ही till it fills up. So you will have to first after till the delivery of the child you will have to change the bottle or something and then do the suction.
प्लेसेंटा की बात से.
हाँ, right.
प्लेसेंटा जब तक नहीं सेपरेट करेगा ब्लीडिंग कहाँ से होगा?
Uterine incision. Uterine incision.
ना uterine incision तो
No, bottle has to be changed. Yes, bottle has to be changed.
Bottle has to change ना, बराबर ना. Point बराबर है कि नहीं? Dr. Pai's point.
Yeah.
But the other question is that the tranexamic acid should be given as a routine to all cesarean patients?
No, not yet. At the present moment, the tranexamic acid is given only PPH occurs. In cesarean section, one trial showed that there is no benefit. The second trial showed that there may be benefit in high-risk patients.
Are you doing it as a routine?
No.
Routine, yes. As
Not
a
in
trend.
cesarean.
We are
Why
giving
don't we all, let's all, अभी अपने बड़े president आ ही रहे, let's start a trial ना to do this multicentric trial करो ना, कि routinely देके और नहीं करके हमारा इंडिया ट्रायल है क्या कुछ?
PG thesis. Our professors are here. PG thesis डाल दे, एक करके multicentric हो जाएगा.
May I request
PG thesis.
Meena to
professors
come
are
up
there
on
at
the
different
stage. We will just give the mementos.
ये बताती हूँ ट्रानेक्सामिक एसिड का बैड इफेक्ट भी तो है, कोआगुलेशन ज़्यादा सर. But then why?
Thanks to all the speakers. Sir, stay here to present the memento to the speakers.
Now we can speak here, na? Because our turn.
डॉक्टर सुकांता मिश्रा का कर रहे थे. So thank you very much, everyone. We'll be starting inauguration here at sharp 7 p.m. So kindly assemble in the hall at 6:30. 6:45 p.m. Kindly assemble in the hall at 6:45 p.m. as we have to start our inauguration, followed by cultural evening and dinner at 8 p.m. So please assemble here at 6:45 p.m. for inauguration at 7. Thank you.
You can have tea and some snacks and enjoy till then, and or those who want to change can go to their